Today's episode of Knoxville Medicine Doc Talk is sponsored by London and Amburn, attorneys at law, healthcare people, healthcare law. London and Amburn, attorneys at law, are proud to support the Knoxville Academy of Medicine and its mission to continue to improve community wellness in East Tennessee.
Hi there. Welcome to Knoxville Academy of Medicine Doc Talks. I'm Elise Denaney, former president of the Knoxville Academy of Medicine, and today I have joining us Dr. Ryan Dabbs, and he's going to talk about something that affects all of us very commonly, especially as we get older, and that is knee and hip problems. Welcome. Glad you could join us today.
Thanks for having me.
So I have knee and hip problems.
That's the most common thing I see in my practice is hip and knee pain. So that's a common problem. Fortunately, we've got a lot of ways to treat it.
So generally, how long do I suffer, I use that term loosely, have it bother me before I decide to do something about it?
Well, you shouldn't suffer for very long. There's a lot of treatments that aren't very invasive to try to help with your pain. So the first most common way to treat it is just an over-the-counter anti-inflammatory treatment. So ibuprofen or naproxen, something like that. And you should go through a full treatment course. Some people will take a day worth of ibuprofen and say it's not helping. But you should go through a full 7 to 10 day course of the anti-inflammatory to decide whether or not it's helping. Then the next treatment option is just low impact exercise. So for hip or knee pain, moving through the pain, moving the joint often helps. So low impact things like biking, swimming, elliptical machines, those are more helpful than running impactful exercises.
Okay. What if I hear it clicking all the time? Is that a bad sign?
A lot of people's joints click and pop. If it's painful when it clicks and pops, then that's different. But you should have that checked out by one of your providers.
Okay. So if I that continues, I finish the full course of the ibuprofen, still having a little bit of pain. Is ice good for it?
Yeah, ice is always good. Ice helps with inflammation. That's the main source of the pain we're talking about is inflammation in the hip or knee. And most commonly it's arthritic inflammation. And that's why the anti-inflammatory helps. And the next most important thing I think is physical therapy. And a lot of people have had physical therapy in the past and may say it's not been helpful and won't want to go through it again, but there's a lot of new techniques and modalities that physical therapists are using that are more helpful. So dry needling, massage, ultrasound are all really helpful things that the therapists are using these days that may help that haven't helped in the past.
I like the idea of massage. I can go for a massage anytime.
Yes. And
Okay.
insurance pays for it sometimes.
Oh, that's even better. All right. So then, we've done all that. Not getting a whole lot better. It comes to you. Then what do we need an X-ray then, and what happens?
Yes, we'll go through X-rays to look at the joint, and then the next most common treatment options are injections. And there's really 4 types of injections that are important to talk about. The cortisone injection, which is a steroid injection, that's the mainstay. That's just a strong anti-inflammatory, and that usually helps for a short period of time, get the inflammation under control. The next type of injection for knees specifically is the lubricating type of a shot. That's the viscosupplement gel injection, and that's a 6-month injection, and that helps some people's arthritic knees. Then the next 2 types of injections are the PRP injections that you may have heard about. That's the platelet-rich plasma. That's where the doctor will take some blood out, process it down, and inject it back in. And that can be helpful for some people's hip and knee pain as well. Then the next most common thing I hear about now is stem cell injections. I think it's really important to talk about that because stem cells are all over the internet. There's a lot of information about it, and some of it's misleading. So really the only 2 sources of stem cell injections in the United States are bone marrow and fat or adipose tissue. And that tissue can be taken out, processed, and injected back in and have live stem cells. But the vast majority of the injections that are given in the United States that are under the name of a stem cell injection really don't have any active stem cells. So if you take some of the amniotic fluid or placental fluid, process it down, and then freeze it, all the stem cells die. And so those are the most common injections that are given around the country that don't actually have stem cells. there's still a lot of healing potential. There's lots of little growth factors in that tissue, and it may help your hip or knee pain, but you want to know exactly what it is that you're getting. So you should talk to the provider, whoever is considering giving you that injection. Ask them where the stem cells or where that injection's coming from, so you know what it is. Because most importantly, it's experimental still. We don't know for sure how the stem cells work and in what way they're going to work, and there can be some risks to the stem cell injections. And it's not covered by any insurance, so it's thousands of dollars for those injections. So you want to make sure you know exactly what it is before you get that injection.
And it sounds like you need more than one.
Often it's recommended to have 2 or 3 injections before you see the full effect of the injection. So it may be several $1,000s, and it's all, again, cash-based, and it's still experimental. So make sure you do your research. You know exactly what you're being injected with and whether or not it has active stem cells in the injection before you have that done.
So you mentioned stem cells that are harvested from amniotic fluid, bone marrow, and fat. That's human, I
Yes,
assume.
yes.
Not your own.
It's all human. It's your own or from another donor.
Or from another donor that's been like screened and
Yes,
all of that stuff.
yes.
It's very expensive. Does it work? We don't know.
Still experimental. It does work. Some of the studies, we don't have real big studies. Some of the smaller studies show it helps. But again, that's mainly pain relief for a short period of time. There's no proof that it regenerates your cartilage and takes away all your arthritis. But pain relief may be worth it for a period of time.
Cortisone will do that too.
Cortisone will do that.
Yeah. So why not cortisone?
So cortisone works for a short period of time. All of these non-operative treatments may work for a short period of time.
Okay.
Then that leads into the operative treatment. So if you failed all the other non-operative options, injections, therapy, anti-inflammatories, then surgery is always an option for some people.
Well, that's good. Go ahead.
There is one other non-operative treatment option.
Okay.
There are nerve ablation procedures. And those are helpful for people who can't have a joint replacement surgery. The nerves going to the joint are deadened by a doctor. They use a little radio frequency probe to kill the nerves around the knee joint. And so the pain may go away, again, for a period of time for people who can't have a joint replacement or don't want to have a joint replacement. Usually it's somebody who's not medically safe to do so. Their heart or lungs are too sick to undergo surgery. And so that's another treatment option that's non-surgical, and you talk to your provider about that.
Well, that sounds like a wonderful alternative because, you know, if I have a knee that's bothering me and giving me chronic pain, which is really frustrating, can change a personality. Having a nerve ablation is a whole lot better than taking a lot of ibuprofen. So it sounds like a good alternative. But does it last?
Usually lasts somewhere from 6 to 12 months.
Okay.
Then the body may regrow the nerves and you may have pain again. Then the procedure can be repeated if it was helpful the first time, and it may last again for a few months.
That is really good to know. I didn't know that. Okay, so let's talk about surgery. So I've had knee pain. I'm not even going to go to hip pain, but I've had knee pain for now 18 months. And I've diligently done everything that we've tried, and it worked. It bought me some time, but now it's still not working so great.
Orthopedics has come a long way in the treatment of bad hip and knee arthritis. So specifically hip and knee arthritis pain, our surgical procedures have come a long way. We've got minimally invasive procedures, and really what minimally invasive can mean 2 different things. It can mean the size of the incision, so if you just have a small incision, that can be minimally invasive, or it can mean there's less tissue damage in the surgery. That's the important part. So you really want to ask your surgeon, are they having minimally invasive surgery because they do less muscle damage or because the incision's small? The less muscle damage you do, then the quicker the recovery, the less traumatic the surgery is, the faster you can return to full activity and the less restrictions you'll have. So that's the most important new advance, as we've really focused on less and less muscle damage in the surgeries that we do. So a minimally invasive approach to, say, a hip replacement surgery or knee replacement surgery does very little muscle damage, That's why we're doing more and more outpatient surgeries. That's why the patient can come in, have a hip or knee replacement, and go home the same day because there's such less muscle damage. And the pain medicine and the pain protocols that we use after surgery is so good, the pain is a lot less.
That's brilliant. So what about in preparation for surgery? I know everybody says don't take blood thinners. We can stop the blood thinners, but should we do any sort of therapy before or after to prepare ourselves for a good outcome?
Yes.
Yeah.
Yes. Pre-operative therapy is really important because if someone has had pain that's limited their strength and function for months and months or years, 18 months in your case, you may have lost a lot of the strength and the function, range of motion. So post-surgically, it may take you many, many months to get back to that same level. So if you can do as much therapy, and that's when seeing a therapist is really important, because they can focus on strengthening certain muscle groups, keeping your pain under control while you get your motion leading up to surgery, then your post-operative outcome will be a lot better.
Yeah, so I need to be patient. I need to understand that this is going to take a little bit of time.
Yes, I tell everybody that. Everybody's different in how they respond to surgery, but if it took you 18 months to get there, it may take you 18 months to get over it, even after having surgery.
And not to give up hope, because there's going to be little twinges of pain here and there, even 18 months out of surgery.
Sure, it's a long recovery. The arthritic pain may be gone, but there may be other sources still of pain and weakness around a hip or knee. It takes a long time to get better. As long as you're making progress, working with therapy or yourself and the physician, you'll get there.
Okay, so I have chronic knees. So, they always talk about the knee bones connected to the, thigh bone connected to the hip bone and all of that. So if I favor one part of my body, is there the possibility of damaging another joint down the road? Like if I don't...
Sure, yes. Any compensation for one particular area leads to an adjacent joint being affected. So that's why posture and kinematics is so important, working from the foot all the way up to the spine, and therapy is really good at that. That's why it's important to work with a therapist, because they'll spend hours and hours with you over the course of months and months, working on every little part to get your posture and your gait and your kinematics back to as good as they can be.
Yeah, especially, I'm older than you, so I don't run anymore, but we still can do kind of core exercises.
Sure. I think the low impact exercises, there's a lot of options for that. But like we discussed, swimming, which is a really good one, low impact, any sort of recumbent biking, elliptical machine, even low impact aerobic classes that are focused on less impact, less twisting and squatting of your hips and knees are helpful. And that'll keep you active.
Okay, thank you. I'm going to go to something technical now. So I'm thinking about, excuse me, a total knee or a total hip, right? And now there's a zillion different choices. I mean, do I want bone? Do I want synthetic bone? Do I want metal? Do I want to be the bionic woman? What do I do?
Well, you should do some research about them so you know what they are. But the main different types we talk about are, there are robotic assisted types of surgery, so we can use a robot to help do a portion of the procedure, and that helps make certain parts of the procedure easier for the surgeon. Then there is a computer-based hip or knee replacement, and the computer will help design a replacement that fits your body better. And that works for certain people with certain conditions. You should talk to your orthopedic surgeon about if it would be right for you. But certainly a minimally invasive surgery with less muscle damage and, say, an accelerated post-op recovery period is important. So having the physician and the therapist all working on getting you back in an accelerated fashion will speed up your recovery and get you back faster.
So I have to be patient. I know it's going to take some time after surgery for me to get back to whatever level that I'm hoping. But, I think it's really important that you talked on, what level am I hoping to get back to? So knowing exactly, having that conversation about realistic outcomes. Tell me about that.
That's really important, to have a really thorough discussion with your surgeon about what your goals are and having realistic expectations. And so if if you're on the same page with your surgeon about what your expectations and what your goals are, you're more likely to get there. But the most common reason for having a bad outcome is unmet expectations or unrealistic expectations. And so there may be other sources of your pain or other things that are going on that are keeping you from reaching your full potential. And so one of those things is depression. And I have a lot of patients who are depressed about their pain or about their current level of function. So I'll encourage those patients to go and be treated by their primary care physician or their psychiatrist for the depression before they have their joint replacement, because they'll do much, much better afterwards if the depression is under control and their expectations are met.
That's great to know, because it's a real tricky balance. Chronic pain causes depression, but depression also causes chronic pain. It's just really interesting, that dynamic that is kind of a tension between those two. So thank you for explaining that to us today. That's a wrap.
Today's episode of Knoxville Medicine Doc Talk is sponsored by London and Amburn, attorneys at law, healthcare people, healthcare law. London and Amburn, attorneys at law, are proud to support the Knoxville Academy of Medicine and its mission to continue to improve community wellness in East Tennessee.